Hi, I am Dr. Nora Rodríguez from Montevideo, Uruguay, and I'm going to introduce to you some aspects of learning difficulties and intellectual disability. What is school from a child psychiatrist perspective? It is the developmental context of children in school age. And to conquer this context is to grow in subjective and cognitive independence. School is the intermediate step between physical and emotional closeness of home and the macrocosm where an adult must adapt, a place of recognition of rights and duties, where children exercise some independence, still under the gaze of adult reference. The child will be gradually transiting contexts increasingly complex, moving step by step towards independence. Now, what is expected of a child at school? Basic skill management and learning increasingly complex contents, modulation of behavior, pay attention, wait your turn, and not disturb others, achievement of a group performance and acceptance of deferred rewards, to organize, to persevere, feel confident that their caregivers are well and wait for their return every day, stand within the expectation of parents and teachers, accept the authority of another adult, reorganize the experience in terms of new codes of motor and verbal expression. The implicit or explicit knowledge of the significance of these achievements is shared by the different actors involved in school: parents, teachers, health team, and the child himself recognize the importance of integration to school. Being part of the school is more than to learn, and to learn, probably, more than to read and write, add or subtract. Being part of the school is to build a place and an identity from the enabling teacher's loop into the peer group. The child or group of children who are excluded from this context or who fail to grab and enjoy it are subjected to a permanent mark on their identity. How do we understand the complexity of the teaching-learning process? We do so as the interplay of three fundamental domains: the individual potential interacting with the school institution and the family and socio-economic cultural environment. It's also important to say that when we talk about individual potential, we are always talking about strengths and vulnerabilities, because the cognitive performance is never homogeneous. Let's talk about the concept of intelligence. Latin word intelligentsia, derived from intelligere, comprising inter, between, and legere, choose, suggesting ability to choose between the various options available. Or we can speak about ability to understand or comprehend, to solve problems, or knowledge, understanding, act of understanding, ability, skill, and experience. Really, it is an elusive concept. New contributions from clinical neuropsychology make an emphasis on combination of different cognitive domains that interact to produce ecologically intelligent behaviors that limit traditional measurement systems. The developmental neuropsychological paradigm recognizes a neuropsychological organization whose structural and functional support is biological and depends on brain structure and function, but prioritizes the concept of epigenesis, that is, how structures and functions are shaped by experience and culture through significant links that give meaning to a world of shared representations. A comprehensive approach must be interdisciplinary, taking into account biological, relational, emotional, instrumental, and social aspects. So, which are the different cognitive domains that interact? Attention, executive functions, nociception, memory, language, writing, reading, math, emotional regulation, and so on. When we evaluate a child, we need to understand the profile of strengths and vulnerabilities and how school, family, and environment play a role for an integrated approach. Intellectual disability is characterized by deficits in general mental abilities such as reasoning, problem-solving, planning, abstract thinking, judgment, academic learning, and learning from experience. The deficits result in impairments of adaptive functioning, such the individual fails to meet standards of personal independence and social responsibility in one or more aspects of daily life, including communication, social participation, academic or occupational functioning, and personal independence at home or in community settings. We are talking about a disorder with onset during the developmental period that includes both intellectual and adaptive functioning deficits in conceptual, social, and practical domains. The following three criteria must be met. A. Deficits in intellectual functions such as reasoning, problem-solving, planning, abstract thinking, judgment, academic learning, and learning from experience, confirmed by both clinical assessment and individualized standardized intelligence testing. B. Deficits in adaptive functioning that result in failure to meet developmental and sociocultural standards for personal independence and social responsibility. Without ongoing support, the adaptive deficits limit functioning in one or more activities of daily life, such as communication, social participation, and independent living across multiple environments, such as home, school, work, and community. C. Onset of intellectual and adaptive deficits during the developmental period. The levels of severity are defined on the basis of adaptive functioning and not IQ scores, because it's adaptive functioning that determines the level of supports required. This is a substantial change in the classification criteria, and it is critical to understand this concept. Clinical training and judgment are required to interpret test results and assess intellectual performance so that we can establish whether the intellectual disability is mild, moderate, severe, or profound. Which factors may affect test scores? Invalid scores may result from the use of brief intelligence tests or group tests. Instruments must be normed for the individual's sociocultural background and native language. Highly discrepant individual subtest scores may make an overall IQ score invalid. Co-occurring disorders that affect communication, language, and/or motor or sensory function may affect test scores. Individual cognitive profiles based on neuropsychological testing are more useful for understanding intellectual abilities than a single IQ score. Clinical judgment is needed in interpreting the results of the IQ tests. This has to do with limits of the techniques applied. We need to know much about results of tests if we don't want to misunderstand the results. We are always watching performance, and this performance could be inadequate for a number of reasons. Adaptive functioning refers to how well a person meets community standards of personal independence and social responsibility in comparison to others of similar age and sociocultural background. So it's very important to consider variables related to normal development and sociocultural context. Involves adaptive reasoning in three domains: conceptual, social, and practical. Conceptual or academic domain involves competence in memory, language, reading, writing, math, reasoning, acquisition of practical knowledge, problem solving, and judgment in novel situations. People actually show a wide variety of strengths and weaknesses in the different items that comprise this domain, even with no intellectual deficiency whatsoever. Social domain involves awareness of others' thoughts, feelings, and experiences, empathy, interpersonal communication skills, socializing abilities, and social judgment. Practical domain involves learning and self-management across life settings, including personal care, job responsibilities, money management, recreation, self-management of behavior, and school and work task organization. So, as you can imagine, intellectual capacity, education, motivation, socialization, personality features, vocational opportunity, cultural experience, and coexisting general medical conditions or mental disorders do influence adaptive functioning. It is assessed using both clinical evaluation and individualized, culturally appropriate, psychometrically sound measures. Standardized measures are used with informants, parents, or other family member, teachers, counselor, care provider, and the individual to the extent possible. Criterion B is met when at least one domain of adaptive functioning is sufficiently impaired so that ongoing support is needed in order for the person to perform adequately in one or more life settings. Intellectual disability is a heterogeneous condition with multiple possible causes, which we can classify in prenatal, perinatal, or postnatal etiologies. Prenatal etiologies include genetic syndromes, inborn errors of metabolism, brain malformations, maternal disease, and environmental influences, alcohol, other drugs, toxins, and teratogens. Perinatal causes include a variety of labor and delivery-related events, and postnatal causes include hypoxic ischemic injury, traumatic brain injury, infections, seizure disorders, severe and chronic social deprivation, and toxic metabolic syndromes and intoxications. IT is a neurodevelopmental disorder distinct from neurocognitive disorders, which are characterized by a loss of cognitive functioning. Other neurodevelopmental disorders like autism spectrum disorder, communication and specific learning disorders, where one or more cognitive domains show vulnerabilities but not general intelligence, what is sometimes difficult to differentiate from a mild ID. Lack of communication skills may predispose to disruptive and aggressive behavior. Gullibility is often a feature involving naivety in social situations and a tendency for being easily led by others. May result in exploitation by others and risk for physical and sexual abuse. Individuals with a diagnosis of intellectual disability with co-occurring mental disorders are at risk for suicide because of a lack of awareness of risk and danger. Accidental injury rates may be increased. Prevalence rates vary by age. ID has an overall general population prevalence of approximately 1%. For severe intellectual disability, prevalence is approximately 6 per thousand. ID occurs in all races and cultures. The age and characteristic features depends on the etiology and severity of brain dysfunction. Delayed motor, language, and social milestones may be identifiable within the first 2 years of life among those with more severe ID, while mild levels may not be identifiable until school age, when difficulty with academic learning becomes apparent. When associated to a genetic syndrome, there may be a characteristic physical appearance. Some syndromes have also a cognitive and behavioral phenotype. In acquired forms, the onset may be abrupt following an illness such as meningitis or head trauma occurring during the developmental period. Although AD is generally non-progressive, in certain genetic disorders there are periods of worsening or progressive worsening. The disorder is generally lifelong, though severity levels may change over time. From a developmental perspective, therapeutic approach includes psychoeducation, psychotherapy, psychopharmacology, rehabilitation, and working with the family in order to seek generalization of achievements. All this means that we need an interdisciplinary team and multidimensional therapy programs that should seek integration and empowerment. An essential goal is to seek self-determination of people with intellectual disabilities, which refers to the recognition of interests, wishes, and preferences of the subject. It requires appropriate support, but will vary according to the extent of the impairment, because we are looking for a subject as autonomous as possible, assuring the best quality of life that can be provided for him and his family.